Hello, this is Dr. Geetha Haripriya, Medical Director, Prashanth Fertility Research Center, Chennai. We have had many international centers. The first one was in Sri Lanka, which is about 15 years old, and we've seen hundreds of patients. And as of now, we've delivered more than 13,000 babies in Sri Lankans worldwide. So this center, now we are planning to upgrade it into an IVF center in Sri Lanka. Now, the second country was Bangladesh, where we have an information center where we do an online consultation and a consultation in our center in Bangladesh. We see hundreds of patients every year. Our third target is Mauritius, and we have had a center for the last 4 years. It was functional for 1 year, and then because of the COVID, we were only having online consultations. But now we feel that we have to step up. There are a lot of patients who actually need intrauterine insemination, and therefore we wanted to set up a dedicated high technology IUI center where we actually, our analysis report is ready within 45 seconds, and if you want a more detailed printout, in 10 minutes. And if we want to prepare the sperm, we have the highest technology to do it, which is called microfluidics, where you use a magnetic imaging and therefore technology. So the sperm separation is done so quickly, so fast and so precise, so your results are much better. So this is the sort of IUI lab which we are planning to put up in Mauritius, and Dr. Trisha has been there with me for the last 4 years, and she has upgraded her knowledge by being with me and by doing a course. So now she has all the qualifications to practice an IUI. And even our IVF patients, the next step when IUIs fail is to go in for an IVF cycle. So we do all our counselings. The main problem which patients face is they don't want to spend too much of time away from their country, and therefore the initial counselling is done there. The initial preparation is done in Mauritius. They come here just for the egg collection, and then they go back. And when they come for an embryo transfer, most of the preparation is done in Mauritius, and they stay here for a month or so, get their embryos back in, and once the pregnancy test is confirmed and the first scan is done, they come back to their country. Therefore, the actual stay outside Mauritius is brought down so much, and this brings down costs as well as it helps them to decrease their time off work.
Okay, that's very good, Dr. Geetha. But now we have seen many patients there in Mauritius who have had repeated failures from IVF. Mostly we are encountering patients who have had 2-3 IVF done in Mauritius or elsewhere and have failed, and then they come to our center asking for our help. How can we provide help so that they can make their dream come true?
Yeah. So the first step is you have to look into the history. Now, the history is very important because you have to find out about the egg, about the sperm, about the embryo, about the uterus, and whether they have anything in their system which actually rejects the embryos. So based on these things, we look at all the tests, and then I think you should go through the history and prepare a case scenario like in the way that I have just said, and looking at it, we know exactly where to focus. So how are we different from the others, and how are we able to give better results? So ICSI is a technique which is normally done, and you see sperm 400 times big, and you select the sperm, and once the baby is ready, it's normally put in an incubator, which is an open system. Daily you take the baby out, check under the microscope for development, and then put it back. With this, success rates in Prashanth Fertility is about 65%, and but this, higher than this, patients who actually fail should go for the highest technology available. So what is high-tech IVF? So we see sperm 7,000 times big. That is called IMSI. So this is a computer-generated image and selection of sperm. And once this top-class sperm is selected, you inject it into the egg, you create the embryo, and this embryo is now put in an incubator called the embryoscope. Embryoscope is the world's highest incubator, designed like the human body. So the quality of the embryo, therefore, is much better, and there is also an inbuilt camera, so there's no need to take out the embryos to check for development. Automatic recording of embryo development goes on, each embryo separately every 10 minutes. There is software which actually analyzes all the data, and this data is then compiled and it actually gives you marks for the embryos. This is called KIT score. So 100 marks, 80 marks, 90 marks. So then you select the 2 top ranking embryos, but before you put it into the uterus, you look at the thickness of the shell of the embryo. If the thickness is very high, then more than 15 microns, then the embryo takes a long time to come out after being put inside the uterus. So we use the laser, thin down the shell, and then put it in so it comes out quickly. And then we also coat it with embryo glue, which is a sticky substance, and if you put it inside the uterus, the success rate goes up to 80%, and the miscarriage rate comes down by 15%. So generally the miscarriage rate in an IVF cycle is between 18 to 22%. So when you put in all this technology, it comes down by about 10 to 15%. So all these are very, very crucial in giving better results. And if the patient actually has multiple failures, we should also think of other problems with genetics. So we actually advise pre-implantation genetic testing of the embryo, particularly when they've had a miscarriage or where they're related and we suspect some chromosomal issues. So we actually take the embryo, we use the laser, take away a few cells, send it for genetic testing. Meanwhile, the embryo is frozen, and when the results come, it comes back as normal, abnormal. If you give 5 embryos, some may be normal, some may be abnormal. So you choose the 2 normal embryos and then you put it into the uterus. This way, your pregnancy rates are much better, your miscarriage rates are lesser, and the time to pregnancy is quicker because you're selecting the best embryo to put back into the uterus in the first attempt itself. The other reason why multiple failures can happen is because the embryos are put in at the wrong time. Now, some people, the window of implantation is usually quite wide, 18th day or 17th day up to 25th, 26th day. But for some, this window is very, very narrow, only a few hours. So, if patients fail, we do a testing called ERA, endometrial receptivity array, which is a genetic study of the lining of the uterus, and it studies about 234 genes, and then it gives you a timing. You have to do it after you give the progesterone injection. It gives you a timing. It says 120 hours or 140 hours, 144 hours. So you follow this rule as it's prescribed, you follow it and put it in at the right time, and you get a success rate. So this is called endometrial receptivity array, and it's a very personalized timing of embryo transfer to help you to achieve pregnancy. So all these things are very important in improving the success rates whenever you have a case of failed IVFs. And the other thing is male infertility. There are a lot of new technology in male infertility, and we adapt that as well to help the couple to conceive.
Okay, that's true. Even in Mauritius, we have lots of people complaining of male infertility, and it's more or less like a taboo there. So whenever they are diagnosed with a low sperm count or even an azoospermia, that is no sperm in the ejaculation, they don't have the proper advice to carry on with the treatment. And how can we help these patients? Should they really go for a donor sperm, because most of them want their own biological babies? How can we help them?
Yeah. The advances in male infertility is tremendous. So mostly we don't go for donor sperms now if the couple really want to do it with their own sperm. So we take a blood test where we measure a hormone called FSH. Now FSH level is normally less than 10. If it is more than 10, that means that there is a defective production of sperm. And there are 3 reasons which we have to look in when we have a 0 sperm count. One, either there is production, very normal production, but it's unable to come out because of a block in the passage from the testis to outside. So this is something which is very easy to treat because you just have to do a biopsy, get the sperms and use those sperms for ICSI. The second is there is production, but the production is low and therefore it's not able to reach outside. And number 3, there is no production at all. So the first 2 can be treated. The last has particular treatment, and when there is no production at all, currently we've been doing a lot of work on stem cell and PRP, and we inject the stem cells and the platelet-rich plasma enriched with growth factors into the testis, and 3 months later we repeat we can do a sperm FSH. Then after that we do a sperm analysis. Sometimes we have seen sperms in the ejaculate. Otherwise, at least on biopsy, we are able to find sperms. Biopsy or aspiration, we are able to find sperms. Generally, in these patients, we need to do a micro TC, which means we look at sperms with a 40x microscope. Only then we are able to identify sperms, because it's so almost there is nothing and you're trying to improve it. So you can only find a few sperms. With a 10 power microscope, it's not possible to do this, and very rarely we succeed. But after we have bought the 40x microscope in 2016, we've been able to identify sperms even in these men who were previously pronounced as having no sperms. So this new technology has helped us to really improve, and now we are combining the stem cell and PRP, doing a micro TC after 90 days, and when we do it, we are able to find sperms in a few patients. Initially our success rate was only 7%, then it went up to 11%, and now currently it is at 20%. Okay, so male infertility, if you really work it out, you can we can help these men. Many of them, when they have low counts, you do a hormone analysis, you identify if there's any hormone problem, give the medications, and with this itself you can get successes in a few patients. But for the others, lifestyle modification, no smoking, no alcohol, and taking good food, and all these things really help. When everything goes beyond and then there's no response at all, then you plan ICSI. And like I explained earlier, in ICSI you see sperm 400 times big. But if you want to really select the top class sperm and give a good result, you can choose IMSI to see sperm 7,000 times big, selecting the top class sperm, and this is injected into it to create a baby with much better quality than been done earlier with the 400 times microscopes.
Okay. The other trending infertility problem in Mauritius is the severe polycystic ovary.
Okay.
And the main concern about these patients is about hyperstimulation. So they have done previously an IVF and they undergone an hyperstimulation. So again, they have the idea and they have been suggested by others to go for a donor oocyte. Should they really go for a donor oocyte when they have severe polycystic ovary, or can we help them without having a hyperstimulation?
10 years ago, we were having a lot of hyperstimulation. Almost every month we were having 4-5 admissions. And but today we have a protocol which we use for polycystic ovary patients, where multiple medications are given, and we identify these patients with their investigations, and immediately when we prepare them with a good diet and all the medications to actually prevent too much increase of hormones. And immediately after the egg collection, we put them on a group of medications which has actually brought down the OHSS rate to almost zero. So now in a year, we have 3 patients with OHSS on admission. So there's a gross difference after we have identified this group of medications. And the other major reason why this has happened is because now we are following a segmentation policy, which means we do the egg collection, we freeze the embryos, and then we put it back in the subsequent cycle. So when you put it back in the same cycles, the HCG, which is secreted by the embryo, increases the possibilities of OHSS. But now we are not doing that. We are freezing the embryos and we are putting it. So these are also very important. And the injection given to actually, which we use as a trigger, if we use HCG, the chances of hyperstimulation is much higher. Whereas if we use decapeptyl or a GnRH agonist, the chances are much lesser. So when we do all these things, then you're almost bringing down the severity of OHSS to almost nil.
That was very nice, knowing about all these technologies, and the most important is that at Prashanth Fertility Research Center, we can see that you take you take care of everything throughout. So from getting the best oocyte, the best sperm, until having no hyperstimulation at the patient side. So this is very great to know about. We have got a new vision and new dimension of all these technologies. And I've also followed this advanced fertility training course here, which was very helpful. I'm sure I've learned a lot from all the doctors here, from yourself. And I'll take all these technologies back to Mauritius, which will be surely benefiting to the Mauritian population. And for now, I'm bringing along the semen analysis procedures and IUI preparation, so we can have better success rate there. Thank you very much, Doctor.